Thank you so much for joining us today. We are hoping some of us will join us very soon. Others are saying they are having challenges with the network. I don't know what is happening, but we hope they will finally find us on the way. So we are looking forward to a great session. These days we are looking around psychosocial support, looking around on supporting our families, their patients. So we have also uploaded these sessions on our YouTube channel. So if you have missed them before, you can still go there and be able to access them. So even if you missed the session, you can go to our Eswatini and be able to follow up. So we are looking to another very important component in palliative care, which is all about psychosocial support. We mentioned when we started this module that in the past sessions, we were looking around on the physical side, which is pain and symptom control, which we covered in our module 1 and module 2. So now we are doing the third module, which is psychosocial support. Then we are hoping to do another module. Mr. Cyprian. Yeah. So may I welcome everyone and request that we do introduce our names on chat. And I know that for nurses, this is the moment whereby they are renewing their licenses. If you will need some points from our palliative care session, we can have them. We do have them, especially if you have attended the previous module, which was on symptom control. That module, I think it has accumulated 15 points or so. So each session is equal to 1.5. At the end of each module, we release participation certificates. So if ever, then you will need to renew your license. You can get the participation certificates from the module with the support from ECO India. So we are able to release those certificates through the platform, but it's only when we have been able to complete the post module test. It doesn't matter that you have to pass it, but you need to complete it. So we do that. So if you have done that, then those emails are automatically sent to your emails. The delay normally is within 7 days post finishing. So even this module, when we are done, we will be releasing those certificates for anyone who have completed those tests. So we request that when the module ends, you will receive your test, then you will be able to finish complete those tests, then you will be eligible to get the points. So this one we are in now has 13 modules. So you can multiply that with 1.5 hours, of which it's more than 10 hours, which is required by awareness and counsel. Means you can use our module as your CPD points, and then, but before you do that, our offices are always available that you can come with your CPD book. We can then stamp it and confirm your hours with you. So it's very important that we attend each and every session. More than that CPD points, it's an experience sharing. So today we are having a didactic presentation on supporting children. So we have been doing one, supporting the patient himself. We looked around the family, we looked around the caregiver in our last session provided by our social work Mercy. So today we have Mr. Lukele who will help us in terms of supporting children, who is our Manzini Regional Palliative Care Nurse. So he will take us through that. And then we will have a case presentation by our social workers today. So they will help us to present and discuss on a case that we can look at today. So without wasting time, may I allow Mr. Lekele to continue with the presentation for today. Thank you.
Good afternoon, colleagues. As Mr. Masano has just mentioned, today we'll be discussing on a very serious or a very important that touches on children. We consider children as a very important family member in a society. So we have seen that taking care, considering we see children are well taken care of, it's a very important task as health workers need to do. So we'll be looking at supportive care for the children of the client faced with serious condition. So we have seen cases like this one. We have seen child-headed families due to the serious illnesses or to the life limiting illnesses for the parents that will leave children with no parents. Sometimes you find that the children have one parent, sometimes both parents are gone due to the serious illnesses or life-threatening illnesses. So today we'll be looking at how best we can do as health workers to support the children to get through or to go through to cope with these situations. So we'll be looking at the impact to the children, impact on children due to the life-threatening illnesses on their parents. Also, we'll be looking at how best we can do to support the children in order to cope as they are going through all these things. We all know that children are going through the most important phase in life. There are developmental skills that need to be established. So they need to not to be disturbed. The developmental skills here need not to be altered. So we have to try by all means to balance. I am not saying we have to eliminate what they are going through, but we have to make sure that they do balance the two parts. They do cope as their parent is ill, as their parent is sick. So we need to make sure that they are going through their life or their care is being well taken care of. So as our introduction here, we see, or we can see that life chronic illnesses are complex, lengthy, and difficult to treat. As palliative care workers, we have seen that in our facilities. We have seen that in the communities, and we can attest to that. We say there are complex and they are difficult to treat. Some other illnesses are not treatable, so they have to go through this. So when one parent suffers from the chronic illness, it has serious consequences for all the family members. So as you can remember, when we began this session, we mentioned that palliative care does not only look at the client, but also the family members. Also the children here are very, 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 very important to look at. So the worries there and hardships spending the parents and the children suffer along with them. So children suffer most when a parent is sick or when a family member is sick in the homestead. So they are very sensitive, they are still growing, they are still developing. So we need to make sure that they balance all that. We also see that chronic illnesses are associated with stress in everyday life. So also with severe pain and mood swings are also of those affected. So this makes parenting more difficult. I remember when we do assessments to the clients, the main thing that they are worried about is the children, especially when the children are very young. You can find that most of the children that we are talking about here are 13, 9 years. So that leaves child-headed families to increase. So raising children at the best of times is stressful for the client that is sick. Sometimes for the other family members that are also affected is very stressful for them. So doing so while managing an illness is even harder. So you can find that in some instances, you can find that the client is already bedridden. So the children or the eldest child has to take care of the client, also to take care of the other young siblings. So it is very important to reach out for them as they are growing. Carefree family activities tend to become rare because even normal everyday life takes a lot of energy. The organizational effort is significantly higher. The mood in the family may be more often tense or irritable. We have seen that in the communities. So let's see how the impact on the children, what is happening, what's the impact on the children in life-threatening illnesses. Children here often take on more household duties, like I've already mentioned before, look for other young siblings. This leaves little room for hobbies, their own interests and leisure activities with friends. I've mentioned earlier on, the developmental stages here are disturbed as the child is growing. They often live with a constant worry about their mother or father, what is going to happen. So we as healthcare workers need to consider that there is a constant fear that the state of health could worsen. We know that we are dealing with unstable patients. Today the patient is okay, and tomorrow is not okay. So everything happens in front of those children. So there is a constant fear amongst them. What is going to happen next? They tend to withdraw or isolate themselves from whatever that is happening in the home due to the illnesses of their parents. So they often hide their own problems and worries because They don't want to put additional strain on their parents. The excessive demands can lead to anxiety, depressive moods, and psychosomatic illnesses. The health risk increases if the illness of a parent overshadows family life for many years without the children receiving targeted support. So as we assess and as we realize that there is this kind of a problem in a family or in family members, especially the children, so we have to do something as healthcare workers. We'll see how best can we support the children. So we may firstly explain to them what is happening at the age-appropriate level, considering the age, considering their level, their ability to understand. We can explain to them as they are going through these processes, as they are going through this stress. We have to explain everything that they need to know as children at their age-appropriate level. So we may use books from the library to help the children understand disabilities, because in every illness, in every chronic illness, there might be a disability that the patient can experience. So we have to teach and educate the children about those kinds of disabilities. So also, we have to set up the system for a family meeting and hold this regularly, because it's not only the children who are affected, also the family members are affected. So we need to set up as care workers the family meeting to see or to check if the patient are coping well as the disease is progressing or as the illness is progressing. So let them choose an activity which can be free to reward them for a meeting productivity. As we are going through the processes, as we are going through the session, it might be the social worker, it might be the nurse, because we do this holistically. As we do these meetings with them, as we hold this session with the children, we have to look at every corner if the children are coping well with the situation. Help them find the hope that can help them let off steam. Earlier on, we touched on the impact of children, that their hobbies, they tend to withdraw. So as healthcare workers, we have to help them to find a hobby that helps them to let off steam. So we have to interview them about whatever they want to be interviewed for. So we have to ask them, what can we do? What can we talk about? Let them be free to talk about anything that is stressing them, anything that bothers them as they are going through this rough stage. We write a postcard, a letter about how they are feeling. Let them have these small books, memo books, to write everything, like a diary, to write everything that they feel, to write everything that needs to be done. It can be the family, it can be the healthcare workers, the ones that are visiting this, the parents or the children, the ones that are setting up the meeting, the family meeting. Write everything that they need to know about this. Another thing that we can do as healthcare workers, we have to find the strength and areas to work on the children. That will help us to bring them to another level. So we have to also to ask them what another child with a parent who has a chronic illness might want to say. We have to use also creative outlets such as art, music, dance. Sometimes you can find the talent there, the hidden talent you can find to that in order for him or her to cope with the situation. Also, we have to encourage them to keep a secret journal that we promise not to look at. So we have to keep a promise there that we'll never look at that secret journal. Something like a diary, so that the child can write everything she feels, everything needed to be done. So allow them to be angry, allow them to cry, allow them to do anything that can be done, because that will all lower the burden, because we do not know how, we do not know what the child is going through as the life illness or the life limiting is progressing. We have to teach them also on how to do one or two of your core jobs. As we are helping the parent, we might also do the wound dressing, we might also do the bed bath, everything that we can do on the line. We have to also to teach the young ones how to deal with, so that anytime they are with, they are alone with, the parents can do all these things to cope with them. In conclusion, when a parent becomes ill or is ill long term, we wonder how it affects the children. Are they okay, as they say they are? How much should we tell them? We consider also the age level. How much can we tell them about the illness of their parents? Also, children living with a chronically ill family member can experience significant pressure, stress, and depression due to their caregiving situations. In some instances, we may find that the child is not doing well at school. We may find that in some instances, a child is not doing well here in the family, in the homesteads. Everything that the child used to do is doing normal, is not studying anymore, is not attending classes anymore, and the interest, the hobbies, they are not normally the same as they were when the parent or when that parent was okay. So now that the parent is experiencing that, the parent is now bedridden, all of these things fade away. Lastly, it is important for us as healthcare workers to realize just how much children are aware of the impact of the chronic illnesses. Children have the unique insight into what happens in their family, but they may find it difficult to talk about their feelings related to chronic illnesses. Hence, we should support them. We should support them in any way, because I mentioned earlier on, children, they are very sensitive in this. When a parent or when a family member is ill, a long-term illness, the person or the family member that is affected the most is the children. So it is very important to realize how much children are aware of their impact in the chronic illnesses. So that marks the end of my presentation, and I hope we will do better. I hope what we have been doing, we will do it again to help those young ones to cope, so that we can eliminate depression, because depression can be everywhere, can also affect the children that we are supporting. So a full support, a support system is of paramount importance to the children at the community. Thank you very much.
Thank you so much, Mr. Kelly, for a wonderful presentation. I hope we have all learned something from this presentation by Mr. Kelly. He has shared very important aspects that we need to do or consider whenever we are helping patients and families. Most of the time, we do have patients, and most of the patients that we see in the facilities are the adults. I'm aware that also, we are all aware that in the country we also have children who are directly or affected by different cancers and other conditions. But today we were looking on the other aspect whereby then when the child is not physically affected by the condition, we end up maybe forgetting about that child of that patient we are seeing in our desk. Yet those children are really affected by the life-limiting or life-threatening conditions. Or when we are talking about a family, we end up looking at the grown-ups in the family who can talk and express themselves over and above anyone else. And then we end up forgetting about these ones who are mute or who are shy or who cannot easily approach you as a clinician or express how they feel. And maybe culturally, we may feel that children has nothing to say about this condition because of how maybe we are culturally sensitive in treating it. But then if in-depth attention could be provided to them, you could then find that indeed they need support and they need our attention as clinicians for them to cope well, to avoid long-lasting wounds, and heal the world. Because if children have not received enough palliative care, you find that then they will not be in a position to cope well in the future. Think of it when a child has been abused physically. When she grows up, he becomes an abusive child. Think of a child who has grown in a family with a life-limiting condition, seeing the mother and the father anguishing in pain, and then that child become a nurse or a doctor or a healthcare or as anybody who takes care of other people. That child, you may find that has been wounded. So we have that opportunity as clinician to make it right. But thank you so much, Mr. Kelly, for presenting it and some of things we can do. But maybe I will give the opportunity to you colleagues maybe to add on what exactly other things we can do in such a situation, or any comment you have had or your experience you have had concerning child and psychosocial support or children support when the family has a child or a relative to this child who is sick. How has you approached it, and what was the experience? You can raise your hand or you can unmute and share what has been your experience concerning that. Anyone who may want to share or add something that you feel like, you know, as clinician, we need to embrace while we are providing palliative care to patients. As far as the children are concerned, we have addressed the issue of caregivers in our last session. Today, we were doing now the other neglected group, which are the children in the family of the sick loved one. I'm watching and looking for someone who wants to raise his or her hand. Anyone?
Good afternoon.
Yeah, Megan.
Yes, thank you so much, Tim. Thank you for the presentation. it is very critical for us to note the issue of children who are going through the journey with their parents, chronic conditions and life-limiting conditions. I have one observation that I made while I was working somewhere else. It is a rare opportunity to meet teachers when it comes to going to school-going children with parents who are sick. Yet it is a very important link that we need to address as healthcare professionals. I think now with our social work team, we do need to create that linkages and partnership with teachers, because we are the first ones to get to know the information about the sick parents. We ask them about their children and we have their record. And if we can, it is critical that we touch base with the teachers so that they are not caught off guard when this child is not performing well. You know, they have a huge number of children to take care of in school. But if this has been reported to them, it also helps them assist this child specifically and maybe tap into other services that could be available to assist the child so that they don't drop their performance and they continue well at school, and knowing that at home, I have the professional long nursing. At school, I have my teacher. And then the children learn to open up and they talk about their feelings while they're going through this, and they feel very supported. And this also works on the anger issues, that they are lowered and they learn to manage their stresses. Thank you.
Thank you, Kameta. My Kameta have shared something that is also important. You mean the issue of looking around the stakeholders that we have, especially when it's children, consider a plan to engage teachers too, so that they can provide support and care and monitor the child even at school and be touched based on reality of what is really happening. As she has just said, I remember at some point while I was still working Shiselweni region, I had a time whereby I found, I would say it's a teenage, but in her early teens, I think around 12 or so. And then there was this elderly patient that we had who had suffered stroke. And then one time I found that the patient has soiled herself almost the whole body. And when I came, then this child has just came from school, and she was on her gloves preparing to bath gogo. So you see that sometimes because the parents of the child are not at home, she tends to become the real caregiver and is taking care of these children. And the trauma she is going through, you will find that even the family is not able to understand what exactly is this child is going through. So it does a lot. And even when they are losing their loved one, Father, there's already an attachment that they have with their lost one. So Father, we neglect them. Thank you so much, Margaret, for sharing that. Is there anyone else who may want to add something before we go to our case presentation now? Yibu, someone else who may want to add something before we give our social workers to, yes, Tandazile. Yibu.
Oh, good day, team. This is Mazin Government Hospital. Yes, we're together with Tandazile and Neliso. Well,
Yes.
congratulations are in order, Mr. K, for a well-articulated presentation. Thank you very much. I think with regards to counseling on children, I think one has to acknowledge the lack of expertise or skills amongst us in dealing with children. I think that one we all need to learn, practice, so that eventually we get to do it well.
Yeah.
My take is that with regard to sharing the right amount of information with children, or telling them just the amount, the right amount of information, sometimes one may ask how much is enough. However, I would suggest that probably, like Mhlanti rightly said it, we might text in the language or in accordance with the level of their development, maturity, and their understanding. However, at the end of the day or at the end of the sessions, depending on the number of sessions we may want to schedule, I think they should know it all that is happening. But the key issue is that we tell them at language or at the level of their understanding, so they will understand and cope with it, and we explore how are they coping with it, and we make sure that they understand it. I wouldn't like that maybe we tell half-truths or some of the information and we hold some. At the end of the day, they should know it all. That the parent has got a terminal illness, eventually will die, which is the case. But let's explore, what do they understand about death, the permanence of death, and explore around those issues. At the end of the sessions, they should know it all. The parent is sick, terminal, will eventually die, and probably will be left with other relatives, as the case may be. But let's try to find a way of doing it all, but of course, with all courtesy, mannerism, and the way they will understand or at their level. I think that's what I may want to emphasize, that they should know it all, but we are very careful how we present information, probably in short gulps, now and again, until we are done, maybe depending on the number of sessions we want to schedule. I think that is very important. Thank you. That's my take. Thank you.
Thank you so much, Mgoni. Yes, we need to do that. Actually, I'm reminded of there's this question in our assessment at Hospice, our system, whenever you are doing an admission or you are doing a follow-up on psychosocial issues, there's a space, there's a question that we usually ask that when we ask the patient and say, is your family members aware of what is going on? So I remember another patient said that, okay, I've told some of my children that I trust, but I've not told others because I feel like it will hurt them and stuff. You know, sometimes we have patients who are playing the game of do not tell scenarios, whereby when you ask them, are they aware? Then some will say, no, I don't want them to know. Some will say, I've told them the other way, but I've cut the other way short. And you find that when the children discover it late, and sometimes they are not discovering it from us clinicians, or they're not discovering it from the family members. Maybe they are getting it from the road, because when you are sick, you chat with some friends and some friends tell other friends, we know this. The other one tells the other one. And the story as it goes, it gets distorted and distorted. You will hear a child saying, hi, Snetemba told me that her mother was told by the cousin that you have cancer. And then by that time, if you lie to that child again, the child will never trust you again, because once you die, the child will never trust us anymore. Even us clinicians, so they look at us and they trust us, and when we lie to them, then they never trust us again. And studies have shown that children, they even if it's them who are sick, They even know that they are going to die even before we even tell them that. And sometimes pediatric, they say that in that development psychology, once they ask you a question, even how sensitive the answer might be, they are ready for the answer. Or they already have some information, but because they trust you, you will give them what is true, they will ask you. Sometimes they will ask, is Mama going to die? And as a clinician, you look at the situation, social status of the family, and say like, but how can I do this? Then you discover that the children are ready to know that. So it's very important that we tell them that truth. And as Numal has said that at their level, but even if we try to go down to their level, let's not try to digest everything until they can understand. I think last year I was watching TV with my son at home, and then I saw a truck with hydraulics, and then my child asked me, "What is this, Baba?" You know, I thought my child, if I say these hydraulics, will be a tough language. I begin to explain the work of the hydraulics, and then this one is what the truck used to balance and lift it up. And then my child finished the statement before I even finished. Oh, these are hydraulics. So that's when I discovered that as young as he was, he is aware that these are hydraulics. And he is aware of many of the things. When you may go to the filling station and try to explain what you're going to do, they're scared to say this is fuel or this is petrol. Before you even finish telling the lie, the child will tell you the truth right straight into your face. So it's a lesson that we need to learn as clinicians, that as we're taking care of their mothers, they are seeing their mothers bleeding sometimes, seeing them squeaking and doing all those things in pain, and they will ask you, and if it's supposed to be cancer, and you just tell them, my mother is cancer. But most of the time, it's very important to liaise with the parent to say your child is concerned about this, and then explain why is it important that we may share with them. It helps a lot, and it helps them to understand, because they begin to get information outside and it destroys them. Okay, I don't know where I'm talking a lot. Maybe ngivayela abantu ngaphandle ngoku. But if there's none who wants to share, I will move to our case presentation. But if there's someone else who want to share something, in a minute, I can share it out. I'm trying to open the case presentation for the social workers. Where is it? Wow. This one. Is it? Can't happen that I opened the wrong document. Yes. So that is it. Yeah. All right. Thank you. So, yeah. So whenever the patient approaches your facility or you will be visiting like we are, let's do some assessment to see about the children. At hospice, we usually ask them about the occupants of the household and how many according to their ages, because they try to extend that it helps us in our psychosocial support wing. It also helps us in understanding the type of people who are in contact with these children. Whenever the parent has a discharge that is smelly, you know patients when they are very sick. And I don't think the children cannot feel that. And sometimes you find that the smell is sometimes sticky to the clothes. Ne? Think of this child going to school with a sticky uniform. A sticky uniform with a child. And when they are approaching their teens, we understand the LLC developmental stages and what they are going through when they are in teens. So think of it. So there's a lot of that damage that happens. So it's very important to get to know what they are feeling. But let me open the case presentation for today by Sebenzile, our social work intern. I hope she has something for us all. So Sebenzile, you can go ahead. Please.
Just as Masham has said, I'm Sebenzile Shongwe from Christian Medical, and I'm a social worker. I'll be presenting on a case of a 65-year-old female who has stage 4 cervical cancer. The main problem or concern I have about the client is that the patient experiences pain primarily on the pelvic region, on the cervix and the lower back. She also feels pain in her legs. And there's also lack of financial assistance, which makes her not to be able to afford herself or to be able to reach the hospital for a scan or colostomy bags. One of the chief complaints that she had was pain on the cervix, abnormal vaginal discharge, which sometimes can be blood clots, cramps on the legs, which can leading to her legs swelling. The pain is located on her pelvic, and the intensity can be 6 to 7, and it happens anytime. And usually it happens when she's walking. Relieving factors is through sleep and relaxing. The impact of the pain, it leads to decreased mobility, and the current analgesics that she takes is tramadol, and for meds effectiveness, it is partial relief. The physical aspects, it is lower back pain. Sometimes she's fatigued and depressed. Then the psychological aspects, the patient has moderate depression and anxiety related to family issues, as she doesn't have a home and she's in a cohabiting relationship. Other aspects are financial issues. The patient has never worked, no occupation, education, she ended in high school, socioeconomic class, very low class, marital status, it's cohabitation, lifestyle habits that are non-harmful. Other social-related information, she's emotionally stressed since they were poisoned as a family in October 2022 by a granddaughter who is now at Mawelawela. She depends on elderly grants, and she also has 3 children who also happens to help her sometimes financially. The spiritual aspect, the patient is a Christian and she believes in God and that she'll be healed from her pain. She goes to Nineveh Church in Zion, but sometimes visits nearby church when she can't afford to go. The significant medical or surgical history, the patient started chemotherapy and radiation in November 2015 and did it 6 times. Relevant past medication, there are none. And then the current medication, she takes vitamin B complex, HCTZ, multivit, ferrous sulfate, cyclophosphamide, and tramadol. DNR, there is none. Preferred priorities of care, there's no. And healthcare proxy, this is no. Advanced statements of wishes, yes. Then information revealed the vital signs have temperature, which is 37 degrees, BP 134, 8.83, pulse is 77, respiratory rate is 16. Echo is 0. And when I'm rating symptoms, pain, in a score of 4, we have, it is in 3. Dyspnea, there is 0. Anxiety is 1. Agitation, there is none. Depression is 2. Drowsiness and fatigue, sorry, it has to be 1. Nausea and vomiting, there is 0. Anorexia is 0. Constipation, 0. Dry mouth, 0. And poor mobility is 1. Further care plan, it is to organize family meetings to enhance communication, individual or group therapy, to address anxiety, depression, and coping with terminal illness, transportation assistance for medical appointments, and provide counseling to the family to address emotional distress, and also facilitate access to spiritual care providers. Thank you.
Thank you. Thank you. Thank you so much, colleagues. I hope we have got it. But maybe to give a summary of what Sebenzile have shared concerning this patient. She's presenting this elderly woman, whom I'm hoping she's getting her grant because now she's 65 years old. But what is so critical and clear is that she's already in stage 4 of cervical cancer, and she has a history of chemotherapy and radiation in 2015. And then the social workers also found that this patient experiences pain. This one it sounds like a mild to severe pain because it's now approaching 7 or so, and which is not responding well to treatment with the partial effect of the pain. And they also said that this patient is also done colostomy and already on colostomy bank. And the issue now at current is that due to the financial constraints, this elder woman even can't afford the colostomy bags. Actually, I was talking with Mr. Dlamini, our clinical manager at Hospice, and was saying that in another vendor, each one colostomy bag may range to 450. Malangeni in another one to around 150, 160. So, and then looking at this woman saying that she has now the challenge of a colostomy bag. I hope now we can have the picture of this family house whereby there are no colostomy bag actually. So the issue is, how is the family surviving, or how is she surviving? Psychologically, I can see the dignity of some. So this is a woman after all, you know, and the cleanliness level challenged at this point in time. Unfortunately, not because it's my behavior, but financial constrictions and then the other discharge that are coming with it. That's what I've taken out of it. Another thing that I've noticed that so there's this swelling of the leg, and then this fatigue that this patient is going through. And I've noticed that even functionality-wise, even though he has not declined that much, but there's that mild mobility issues. And it means maybe sometimes it might be severe if she cannot always be able to reach change. And then there's also these social or psychological issues, especially the stress that she has, that they've experienced some poisoning. Kunabului lapha ekhaya lapha. So yeah, it's one of the issues. The family relationship or dynamics looks unstable at this point in time. I don't know what we can do, how best we can support such a patient, but the social workers are here in the house. If there's something maybe we may want to know better, I hope social workers will answer. I don't know when it's in case of clinical expert like nurses, maybe they will help us to get the regionalness. Yeah, but I don't know, what can we say in such a situation? Yeah, how best can we support this one? This is what the social workers have met on the ground. And, yeah, is there anything you like? What? Yebo, Tandazile, I can see you are mute.
Yeah, hi, good afternoon, team. Good afternoon, Matlang.
Yebo.
Thank you so much for the case presentation. I'm just thinking, I don't know how best can this be handled. Like you were saying, Maggie been treated with chemotherapy radiation. So I don't know how far they discussed with the doctors, because I think for most of our clients, before they make these decisions, whether to go for any surgery, to go for whatever intervention, they should be given like all the information so that they can make an informed decision. I would make an example. You might find that even the colostomy that was done, it's not to benefit him much, considering Guti actually done. He's not on active chemo, I think, at this point. So probably the client would have probably, after discussing with the family, I would have said, if we are going to have to spend money buying these expensive colostomy bags, then rather let's not go for this one. So I don't know how much we are into discussing the goals of care as clinicians, or we just assume that whatever we say they should follow through with, without actually considering their socio-economic and other issues on the background. I really we are so much lacking on that one, because rather than doing much for the client right now, they are so much frustrated.
Yeah.
So I don't know how can we handle this one. I know we have issues of human resource. We have a lot of issues, but I think it is only fair to say, if you have encountered one client, do justice. Whatever decision they take, that they're actually hidden costs, but with whatever interventions that we are suggesting, so that they may be able to say, you know what, rather than going for this intervention, let's just leave things at this and we'll see what happens. Then also they mentioned the issue of depression. With depression, drinking moderate intervention, do we have a plan? Does the client probably need interventions, or we think psychotherapy is enough? I think that should be it for me in terms of managing the depression.
Yeah. Thank you so much, Simelane, for that. Yeah, actually, as you are talking about the issue of goals of care, I think last month, but not far away from today, in our OPD, another client presented with cervical cancer with fistula, and then was done colostomy, and then in need of colostomy, but he came using a plastic. And then she came to us because she has heard that we sometimes have colostomy bags. So she hoped we could rescue her, but that time we didn't have. So what happened is she shared that, you know what? And she was crying by then. She said, you know I have this type of cancer. I think she started her chemo because they said then after that she's going for chemo. She said that, you know, if they have told me that I will have to buy this colostomy and how much it cost, really, I will not accept this, because now it is not helping at all, actually making my life worse than before. So yeah, I don't know, but I think we need to improve, not sell velvet cake to the patients, but be realistic indeed, as you are mentioning. That, okay, I'm giving you this, and this is what I'm hoping it will do based on evidence, and these are the consequences out of it. The good part of it is this, the bad part of it can be this, but I wish we can take. Actually, at this point in time, because the consequence that they go to after, they are so much. So thank you so much for sharing that. I don't know, Mzizi, you can share something about this case, because Shoma says you know about the case. Nathan Conda, I don't know if you can say something concerning this case. Is there anything you may like to share? Mr. Mkonda. Okay. In the absence of Mr. Mkonda responding, colleagues, I don't know, but I'm hoping maybe the team will be in a position to work around the issues of colostrum bags. For that reason, I was requesting Mr. Mkonda to respond on this case, but it sounds as is not hearing us. I don't know, because I can see he is connected. I don't know what's happening. So yeah, otherwise that's it. Anyone else who may want to share something concerning this one? I think also on the issue of pain, I think there might be a need to do some assessment and looking at the inflammation of the leg, how is it going? And finding out, because currently the issue of morphine is a challenge in the country, so we are challenged on dealing with it. So maybe as we have the tramadol in our stocks, maybe we might need to edge activate on it. Maybe it will have some effect, but as we have been doing it in the past presentation when we were looking at the opioid conversions, that 1 milligram of morphine is equivalent to 10 milligrams of tramadol, which means then now we will easily reach the ceiling of tramadol. Maybe we find that we are still not making it through. And let alone the age and the pharmacokinetics of tramadol, we might not achieve, because the transcription to morphine might not work successfully for us. So I don't know, but maybe another depression that this client is going through, that is mild or moderate, might be also aggravated by this pain, except the stress of the poisoning at home, of which I think this must be sorted, because when the family is in the midst of bullying, and this patient is approached, it's in stage 4, and we all know stage 4 might not be treated, it will not be treated, because now it means the cancer is all over the body. And yeah, so sitting down with the patient, discussing on the way forward with her in terms of advanced care planning and the issues of WULO issues, how then it can affect the care she can get from the family members, and maybe sometimes get to meet some of the family members to see what's their relationship with the mother or this client, and how best they are supported. Maybe will help us achieve the patient's goals in terms of quality of life. So I don't know, I'm just thinking out of the box. I don't know if anyone may want to add something. So nobody else wants to add something. Thank you so much, colleagues, and We are hoping one time we will end up having the breakthrough, but currently we are using the tramadol. I don't know if also internationally we are having the tramadol, or we have already getting some stock of morphine there. On our side, we are still using tramadol. I don't know for you, for your opioids, what do you have on stock?
Okay.
All right, thank you so much, colleagues. With this presentation and the case, I am thinking on the 25th of September, we will have session number 9. We will be looking at grief and bereavement management. How then do we help them? So session number 9 on the 25th of September. And then after that, we'll be looking at spirituality and spiritual care. And then we'll look at the concept of spirituality, then we look for sexuality. So we are approaching the end of this module. So on the 25th of September, we will be doing a grief and bereavement support for almost all the groups. How best we can do that, and how best we do that, and when do we start it, and how do we go around. So thank you so much for joining today's session. Let's meet on the 25th of September. Bye-bye.